Research is the cornerstone of innovation in clinical practice, driving improvements in patient outcomes and shaping the future of medicine. Welcome to the Global Rhinology Network Topical Research Symposium. I'm Ashok Rokde from Winchester, UK, and it is my privilege to welcome you as a host. Joining me as co-hosts are Louise Melia from Bath, UK, and Professor Thibaut van Zelle from Ghent, Belgium. This symposium showcases fascinating topics across 4 key modules: General Rhinology, COVID session, and Research in Chronic Rhinosinusitis. A special highlight is the PhD session featuring research conducted by enthusiastic young rhinologists who represent the future of our field. This symposium brings together leading global minds in rhinology who will highlight latest developments with a focus on translating research into impactful patient care. The Global Rhinology Network is dedicated to advancing knowledge innovation. Thank you for being part of this exciting journey. Thanks to Medtronic and Karl Storz for their generous support in making this symposium possible. Welcome to GRNTopical Research Symposium.
So the first speaker in our PhD session, which is the last session of today's session, is Saaetje Uyttebroek, who's currently a resident in otorhinolaryngology at the University Hospital of Leuven. She has a very strong background in research with multiple publications, and today is going to discuss her PhD project on the role of the ENT surgeon and the management of CF patients in the era of CFTR modulators.
Thank you very much for the kind introduction. Can you see my slides? So good evening, everyone. Thank you very much, first of all, for inviting me for this very interesting afternoon. So today I'll give you some sort of PhD pitch. So I'll give you an overview of what I've been doing right now. So I'm currently based as a resident of ENT in Leuven, and I'm also doing my PhD. And I'm mainly working on how we should manage difficult to treat chronic rhinosinusitis, both in patients with and without cystic fibrosis. For the sake of time, I will only focus on these CF patients for the moment. So cystic fibrosis is one of the most common genetic diseases in the world that affect around 52,000 patients in Europe alone. It is caused by a defect in the CFTR channel, and when this channel doesn't work properly, it causes buildup of mucus in several organs and leading to impairment, for instance, of the paranasal sinuses. Unfortunately, the treatment options for the CF-related chronic rhinosinusitis are very limited. But in 2012, the first modulator was approved. It's called ivacaftor. CFTR modulators are really changing the CF perspective. It's going these are drugs that are able to restore the CFTR channel and that are improving the lung function, the quality of life, etc. In Belgium, we are a little bit late with the reimbursement. So only in 2021, we got reimbursement approval for the combination of tezacaftor, ivacaftor. And only in September this year, we got reimbursement for the highly effective combination of Alexa, teza, and ivacaftor. So it's really changing CF from a really symptom-based treatment to a disease-modifying treatment. So when I started my PhD in 2020, I really wanted to have an overview of the disease severity in the CF population. So I included adult CF patients at a pneumology clinic. I asked them to fill in a questionnaire. I did an endoscopy, a sinus swab, and a CT scan, and I used several scoring systems for it. In total, I included 122 patients with a mean age of 33 years old. The majority had at least one F508del mutation, which in our region is the most common mutation causing CF. And if we then look at the number of patients carrying higher risk mutations, we see that these are the majority of the patients. With higher risk mutations, we mean that these are patients that have severe mutations and they are generally causing a more severe CF. Half of the patients almost were treated with a modulator, with the majority on the triple therapy in a compassionate use setting, and then 1 out of 3 with a combination of tezacaftor and ivacaftor. In 12%, they are routinely followed up in the ENT department, and in 1 out of 4, it was even the first time that they saw an ENT specialist. Almost half of the patients uses local steroids on a daily basis, and 25% uses daily rinsing. And in 43%, there was a history of previous sinus surgery. If we ask these patients what kind of symptoms that they have lots of complaints that they report, with the top 3 being nasal obstruction, postnasal drip, and rhinorrhea. But if we then look at the severity of these symptoms using a VAS score and a SNOT-22 score, they score relatively low. As you can see here on the graph, there's really no correlation between the SNOT-22 and, for instance, the CT score using the Lund-Mackay score. These are patients with very severe objective disease, and they have very low SNOT-22 scores. On endoscopy, we see polyps in 32% and purulent discharge in 1 out of 4 patients. In almost half of the patients, we see colonization with bacteria, mostly Staph aureus and Pseudomonas aeruginosa. And even almost 40% of the patients has multi-drug resistant strings in their nose. 76% of the patients has sinonasal inflammation, and anatomical variants were abundant. If we compare patients with high versus low risk mutations in disease severity, we don't actually see big difference on SNOT-22 scores. We see a relatively higher CT score, but the difference was not statistically significant. Also, the number of sinus surgeries is comparable in both groups. If we then compare the patients that are treated with and without the modulators, we do see the same comparable SNOT-22 scores and nasal endoscopy scores. We don't see a big difference in it, but we do see lower upper airway colonization in the patients that are treated with the modulators, and also significantly lower CT scores are observed. So this is showing that these modulators might be very promising in the treatment of CF-related CRS. But the main limitation of this study is actually the fact that it's an observational study with a cross-sectional design, and therefore we are extending our database to include also patients that are treated with the modulators and have before and after data. So as I already mentioned, in 2021, we got approval to reimburse tezacaftor, ivacaftor, and since then we do have before after data from 18 patients 1 year after they were started with tezacaftor, ivacaftor. We don't see a big difference in SNOT-22 and in the CT scores. This can be explained by the fact that it's a relatively large sample size, but also because these 2 modulators are not very efficient in the treatment of patients with our F508del mutations. It's more for the gating mutations. And now in September, we started also including patients to have a more an idea of 12 months after starting with the triple therapy. Here is an example of a patient before that they were treated with the CFTR modulator, and this is 12 months after starting the triple combination. So we do see a very good improvement in the CRS. So we will see how this will bring us. So the big question is, what is the role of the ENT surgeon? And then I stress the fact surgeon in this CFTR era. Do we still have to perform sinus surgery on these patients? Well, that is a big question. The second question that pops up regularly is, do these patients still have to continue their nasal irrigations, continue their local steroids? So these are questions that we have to answer in the future. But nevertheless, there are still a big group of patients that is not in Belgium eligible for these CFTR modulators. For instance, patients that have already undergone a lung transplantation or patients with rare mutations, they get not reimbursement for these modulators and they cannot get the treatment. So in these cases, we still have to find for treatment alternatives. And we really have to, when we look at new alternatives, have to keep in mind that the pathophysiology of this cystic fibrosis related CRS is different from the ones that we are used to. It has a more neutrophilic infiltration pattern. It has biofilm formation. It has bacterial colonization. So we have to keep that in mind. So in my PhD, I will mainly focus on some antimicrobials and antibiofilm agents. In the first session, there was also some discussion about the bacteriophages. So I will just shortly give an overview of the projects. I will not go into detail, so please, if you have any questions, let me know. So I will just combine both lab experiments and clinical trials. So for my lab experiments, I will have a look at bacteriophages, but also other agents like xylitol, recombinant DNase, and sodium bicarbonate to see if these agents are able to prevent biofilm formation and treat biofilms. And therefore, I work together with the lab of pharmaceutical microbiology in Ghent, where I will be growing strains that I isolated from patients in a sputum medium that is adapted for CF. And I will grow these biofilms and treat them and then compare the CFU counts for these measures. Then there's also some clinical projects. So first I will compare xylitol and saline nasal irrigations in a randomized crossover trial that looks a little bit like this. So patients will rinse their nose once for 6 weeks with both products. And then lastly, I will just show a general overview of the project that we're doing with our bacteriophages. So phages are viruses that are able to infect and lyse bacteria. So they inject their DNA, replicate within and cause lysis of the cell, and then they move on until the next bacteria until an infection has resolved. We did a review to look if these phages can be used to treat difficult to treat infections. Phage therapy is considered to be safe, but we don't have a lot of big data yet on the efficacy. So therefore, in 2020, in our hospital, we started the Phage Force project, which is actually within our hospital a project that we can treat patients. So it's really a clinical framework, so we can provide treatments and follow-up data. So it's not really a clinical study, but it's more a database that we set up. So we can treat patients with cystic fibrosis, lung infections, sinus infections, but also musculoskeletal infections and sepsis. How does it work? So if you want to get more into detail, we have published our protocol, but when there's a patient with very severe recalcitrant CRS caused by Staph aureus or Pseudomonas, so it's more like a type 1 disease, we discuss the file on a coordination group for phage therapy. We test the phage sensitivity for the bacterial strain using a phagogram. And when there's a phage available, we start the treatment, which consists of nasal irrigations. When there's no phage available, the patient is included in a standard of care group. So this is actually how this Phage Force project works. So if you have any questions about it, please let me know. So that was a quick overview of the project that I'm doing right now. So even in this era of CFTR modulators, we still see a high prevalence of cystic fibrosis related CRS. We have to be careful between that there's no correlation between the patient's reported scores and the objective sinonasal disease. The modulators are very promising, but we're still waiting for our results. And in the patients that are not eligible for these modulators, we still have to look further for treatment alternatives. Thank you very much. I would like to also thank the rest of my team. If there's any questions, I'm happy to answer them.